Gestational diabetes. What is it? Who gets it? What can I do about it? You just found out you have gestational diabetes. Now what? Gestational diabetes mellitus is diabetes diagnosed in the second or third trimester of pregnancy that is not clearly overt diabetes. According to a 2014 analysis by the Centers for Disease Control and Prevention, the prevalence of gestational diabetes is as high as 9.2%. Many women develop gestational diabetes. However, a diagnosis does not mean that diabetes was present before conceiving or that it will remain after giving birth. Who gets gestational diabetes? Although all of the causes of gestational diabetes are unknown, there are a variety of different risk factors that have been identified. Low risk factors include a normal weight before pregnancy, age less than 25 years, no diabetes in the immediate family, no history of glucose intolerance, and no history of poor obstetrical outcomes. High risk factors include obesity, non-white ethnicity, high blood pressure and cholesterol, a history of gestational diabetes or glucose intolerance, and a family history of diabetes. Many women can present without symptoms, but some may experience increased thirst, weight loss, fatigue, increased urination, nausea, frequent infections, vomiting, and blurred vision. So how does this happen? When a woman becomes pregnant, the placenta produces hormones which may help the baby develop but can inhibit the functioning of insulin. As a result, the mother has increased blood glucose levels due to insulin resistance. The insulin resistance makes it difficult for the mother's body to use insulin. The mother's blood then carries the extra glucose to the fetus, and the fetus makes more insulin to handle the extra glucose. The extra glucose present then gets stored as fat, and the fetus becomes larger than normal, which can result in many complications. Blood sugar that is not well controlled in a woman with gestational diabetes can lead to many problems in both the mother and baby. For the baby, it can result in macrosomia, or large for gestational age, respiratory distress syndrome, neonatal jaundice, abnormally high red blood cell count, low calcium and magnesium levels, and shoulder dystocia where the shoulders fail to deliver shortly after the fetal head. For the mother, she may experience preeclampsia and gestational hypertension, birth trauma, and an increased risk for developing type 2 diabetes in her future. Women who become pregnant and have high risk factors are tested for undiagnosed type 2 diabetes at the first prenatal visit. Those who are not previously known to have diabetes are tested between weeks 24 and 28 of gestation for gestational diabetes. This is done by completing a one-step or two-step oral glucose tolerance test. If at least 2 of the blood sugar readings are higher than normal, the patient will be diagnosed with gestational diabetes. After diagnosis, treatment typically starts with medical nutrition therapy, eating healthy, being physically active for at least 150 minutes per week, and frequent glucose monitoring. A majority of women diagnosed with gestational diabetes can be controlled with lifestyle modifications alone. According to the ADA, insulin is the preferred agent since there is a lack of long-term safety data for non-insulin agents. As seen in this table, target goals in pregnancy are more stringent than for a non-pregnant woman. Gestational diabetes should not be a condition of concern if monitored and treated correctly. Proper management and lifestyle modifications can result in positive outcomes for both mother and baby.